most common lines of business among the payers who responded was commercial and Medicare Advantage. And in both of those groups, there was about 2/3 of payers who had those lines of business. And there was slightly less involvement in Medicaid, and that involvement was split between fee-for-service and managed care. So the first set of results I'm going to share are referring specifically to how payers are using telehealth services and payments and supports for those types of services in their interactions with primary care practices. So this first slide shows how many payers are covering different types of telehealth services and how that compares when you look at what primary care demonstration programs those payers are participating in. And as you can see, nearly all of the payers are covering video, or at least HIPAA compliant video and audio or telephone only telehealth services, but there are smaller proportions of payers who are providing other types or paying for other types of telehealth services. And although I'm not presenting the slide on this, I will note that not-for-profit payers are more often paying for things like asynchronous interactions and remote patient monitoring compared to for-profit payers. And so while it was very promising to see such high rates of telehealth services use, we know it's also at least equally important to know how much is being paid for those telehealth services. So we asked a question about payment parity and whether payers are providing the same amount of payment for telehealth services compared to in-person care. And all but 5 payers are reimbursing on par or with parity between those two types of services at least some of the time. As you can see from the slide, the breakdown is a little higher if you look at always paying at par in the not-for-profit payers compared to the for-profit payers, but the green and blue boxes respectively are payment parity all the time, or it varies is the blue. There were some other insights we gleaned from other questions that I think are useful to know as we think about what types of telehealth payment and amounts of telehealth payment payers are providing. So we know from the survey that about 1/2 of payers have reported differences in how much they pay for telehealth payment and whether that payment is on par with in-person services between lines of business. We also know when we asked about the most common drivers of the amount of telehealth payment that the visit length is the most common driver, followed by things like whether a patient was a new or established patient and the clinical complexity of the need. So I said that the survey is really a point in time assessment, but there are a few opportunities to think about how things have changed relative to early 2020 because of the first survey Milbank conducted. And this is mostly in the context of the telehealth data. So we know from the 2 surveys that it appears, I shouldn't say we know, it appears that the payers surveyed have more often been covering telehealth, at least in the context of telephone and audio services, compared to how they were providing coverage for these types of services in early 2020. There was also a bit of a bump up in video, but it's a smaller difference. It also appears that there is greater payment parity, or at least not less payment parity compared to early 2020. It's a little harder to tell because the payment parity data we had from the first survey looked separately between video and telephone types of telehealth services, whereas the survey this round asked about telehealth overall. And you can see the note on the slide, but I'll just say it out loud to be clear. The reason I'm being a little cautious in calling this clear proof is because we know the survey was distributed to different people. Although there was some similarities in the respondents, there are some differences in who received it and who had an opportunity to respond. We also know that participation was voluntary. So we're a little sensitive to the fact that we don't have perfect proof, but this does seem suggestive of an overall trend. Now, we've talked about payment for telehealth services and how much that payment is, but we know that use of telehealth is affected by way more than just what is available. So we asked a question to understand how payers are using different mechanisms to support primary care practices and patients in using telehealth services. And as you can see from this slide, many payers are using not just one, but actually multiple mechanisms to provide this kind of support. In fact, 2/3 of the payers who responded are using 3 or more mechanisms to support the use of telehealth among their members and their providers. You can see this from the slide, but I will just call attention to the fact that the most common mechanisms that are being used are engaging members to use telehealth to increase primary care access, and also making changes to both attribution methodology and quality measurement approaches. I know we have time at the end for questions, but this is a natural break because we're about to shift gears and talk about the results we saw as it comes to other types of payments. So I want to pause and see if there are any questions or reactions people want to offer at this point, or that they may have submitted in the chat that I might not have seen yet about the telehealth data so far.
Yeah, this is Lisa. There's nothing in the chat at the moment. Does anybody have any questions for Alyssa or her team right now?
I'll keep going.
Okay.
And people, I'm sure, hopefully will have other thoughts at the end, if not at other points in the presentation. So shifting gears to talk about other kinds of payments, we asked about two sort of lenses of types of payments that are worth thinking about. The first was asking about what kinds of advanced or accelerated payments payers are offering primary care practices. You know, I think they are offered for a variety of reasons, but especially when practices have need of additional or earlier access to cash. So we learned from that question that most payers are offering at least one type of advanced or accelerated payment. You can see that there are some variation in sort of how much practices are offering certain types of payments, but at least when we can look at the differences between not-for-profit and for-profit payers, we see a slightly higher percentage of not-for-profit payers are offering prepayment of quality-based incentives compared to for-profit payers. To give you a sense of some of the other responses we received, you can tell from this slide that there was a fairly substantial number of payers who indicated that they had other types of advanced or accelerated payments. Some of the examples listed were prospective payments of things like care coordination fees, additional payments to practices to account for COVID-19 difficulties, for instance, targeting certain types of providers such as pediatric practices or oral health providers, and at least in one case, a payer indicated providing loans. We also asked about ways that payers are modifying quality reporting requirements in 2020. You can see that not everybody is making modifications, but the majority of payers are doing so. More for-profit payers are modifying their 2020 quality reporting requirements compared to not-for-profit payers. To give you some numbers here, about 3/4 of for-profit payers indicated that they are making modifications, whereas less than 1/3 of not-for-profit payers had the same indication. And you can see that there are some examples beyond the types of modifications we've listed on the slide of other ways that payers are making modifications. Things like waiving quality reporting requirements or selecting the measures that are the better of the two options, for instance, making analyses based on prior year's performance and the current year's performance, and then selecting which of those metrics was better for a given provider. Thinking both about the advanced and accelerated payments and those quality measurement modifications I just talked about, I do want to put a quick note in here that it looks like these approaches and these policies are likely to be temporary. You can see from this slide that about half of payers indicated that these approaches, advanced or accelerated payments and quality measurement modifications, are likely to be temporary. Whether they were newly added or modified, they still look like they're likely to be temporary. By comparison, when we ask the same questions, looking at things like use of telehealth services and payment for telehealth services, less than 15% of payers indicated that they expected those supports and programs to be temporary. In both cases, there was a large number of payers who said they are not yet decided about whether or not these things will be temporary, but it does seem to suggest that unlike telehealth, advanced or accelerated payments and quality measurement modifications are probably going to be temporary to the pandemic and not continue beyond. We also asked, again, and still in the vein of payment, whether payers are increasing opportunities for primary care providers to participate in alternative payment programs. And the answer seems to be yes. Most are offering increased opportunities, most often just for one type of model. There were some payers who had more than one type of model that they are offering increased opportunities to for primary care practices to be involved in, but most often they selected one. And there were some examples that examples of ways that payers are expanding access to providers that I thought were useful to share as you think about sort of what the implications of this might be. Some payers are encouraging provider participation through things like targeted outreach. Others are adjusting their program policies, for instance, reducing their minimum patient thresholds. And finally, some payers reported they're increasing more gradually things like benchmarks or levels of risk in a way to encourage participation among providers. We also knew in the first survey that providers are offering a variety of other supports that are not related to telehealth or not related to the kinds of payment programs we just talked about. But we didn't have insights from that first survey about how frequently these are being offered. So we wanted to use this round of the survey to get some more insights into the types of other supports that are offered and how frequently. I chose to put on this slide, rather than the overall numbers, the comparison between for-profit and not-for-profit payers, because I think there are some interesting differences that might be useful for you to note. I will mention, as you're taking a look at the slide, I won't read through everything. You can see both the slide itself, but also the list of which types of supports are more common for not-for-profit payers or for-profit payers on the right. That some of the other examples of supports that payers listed were things like waiving prior authorization requirements, conducting new analytics, for instance, COVID-19 predictive models, providing community supports, for instance, for frontline social services, and also providing personal protective equipment to providers and practices. I'm going to shift gears again and talk now about some of the factors that influenced whether and how payers took these approaches and the things that made that difficult or easy. So first off, we asked a question to try to understand what facilitating factors influenced how payers are able to react. And overall, the largest number of factors, or the type of factors that came up most often were actions, sort of external factors, actions of state and federal regulatory agencies, things like changing policies, putting out new mandates or guidance, things that offered new options or flexibilities to payers. And that was something that we saw in about half of the payers who responded. Sorry, a third of the payers who responded, I misquoted there. Some payers also mentioned internal factors that influenced their ability and made it possible for them to respond in the way that they did to support primary care practices. And you can see them listed on the slide, things like leadership of the organization or their company values, prior investments, particularly in things like technology and telehealth. And also in some cases, we saw mention of the benefit of the organization's flexibility and how that made it possible to implement new policies and supports. Some of the other facilitating factors that payers listed were things like feeling an obligation to act, the benefits of collaborating with other public and private sector payers, using analytics and dashboards to inform both decision-making, but also for monitoring purposes. And in a small number of cases, there was mention of the benefits of being a health system or provider-owned payer. That said, there were definitely some difficulties, as I'm sure none of you are surprised to hear. Most of the payers who responded indicated they encountered at least one kind of difficulty. Most commonly mentioned was just the difficulty in securing time and resources to identify and make the types of changes that payers wanted to make. Some of the examples of that were the time required to do things like change billing policies or update software, renewing contracts, which often was necessary to do before certain types of supports could be offered, or identifying which providers were most in need of support. There was also a great amount of uncertainty and an ongoing evolution in the pandemic response, and that was compounded by the fact that payers felt the need to respond quickly. So that those two things in the middle of this slide, I think, definitely played together to make things particularly challenging. Some of the other difficulties that were mentioned that are not on the slide that I think might be worth mentioning here, some mentioned that some providers were concerned or resistant to changes. Others referenced the challenges in transitioning to a remote work environment as the pandemic was happening and as these changes were being implemented. And then there was also some mention of challenges in ensuring the quality of virtual services as those were beginning to be offered. While our survey can't show causality or really prove what impact these policies and programs had. It was only asking payers what they did. We did ask what impacts they had observed, and I think we see some really promising signs of how these policies and supports were beneficial to primary care. First and foremost, we saw a number of different ways in which the policies and programs really did protect providers, practices, and the network of every payer. Things like keeping providers and patients safe, keeping practices open, maintaining members' access to care, reducing the number of no-show patients, and sustaining or improving cash flow were all cited as examples of how the actions of the payers protected these critical groups and members of the network. 8 payers also cited substantial increases in the use of telehealth services in primary care, and at least one, although I hope this is not a perspective that only one payer has, predicted that they would see a continuing trend in terms of uptake and use of telehealth even after the pandemic ends. A few payers mentioned that they had received positive feedback from providers, indicating how much they appreciated the actions and supports that were offered. And then there were a few other examples of impacts that, again, I think are worth mentioning, but were cited by fewer number of payers in the survey. For instance, increased provider support for and openness to alternative payment approaches. They saw that some providers were more interested in having those conversations and considering entering into alternative payment approaches. And some also mentioned maintaining or improving quality ratings during the pandemic as a sign of impact. Although it's different, I think, in many ways than the rest of the presentation I've given so far, before I open it up for conversation, I did want to call attention to one other question we had in the survey that I think provides some really useful insights that are critically important to consider at this stage in time, which is we asked how payers are addressing health equity and disparities in primary care. I'm not going to go through all the examples on the slide, you can read them, but there was a variety of approaches that are being used. And I think many of these are things we've seen play out within healthcare generally over the past couple of years, and different ways that people are considering addressing equity and disparities in healthcare. But I also included the quote on the right because it spoke to me as an example of how these approaches don't have to be done on their own. They can work in tandem with one another. And I think in this case, a payer was describing a variety of things that they are doing to address equity and disparities, and the ways that they're sort of tailoring their approaches to particular needs or particular groups. And I thought it was a very powerful quote that speaks to the benefit of doing that and the power that that could have in really addressing these critical needs. So overall, taking a step back from the results we saw from the survey, I think it's pretty clear that payers are employing just a wide array of approaches to support primary care practices during the pandemic. I think it's clear that they are definitely trying to support primary care practices. I think we have some hints that those approaches are successful, at least in the near term, but we don't know what the long-term impacts are going to be, both on payers, but also on the practices within their network. It also seems pretty clear that the new and modified policies and supports have accelerated the adoption of telehealth and potentially of alternative payment models, but it might take some time to see some widespread adoption of those. And that might be especially true in cases where the uptake of particular services might be hindered by perceptions of what is allowed, especially if things that were previously not allowed are now allowed. For instance, the use of non-HIPAA compliant video telehealth services. And it's not clear from the survey, given the way that it was designed, whether these trends will continue and increase, but it seems likely that whether they continue and how they continue will depend on the degree to which these policies and supports are sustained after the pandemic. And as we talked about earlier, there's some uncertainty in the longevity of some of these policies and supports. That's the end of the presentation I have. As I mentioned, I do have other slides in this deck that I'm happy to pull up if people wanted to dig into other areas, but I mostly want to open it up and see if there are any questions from all of you or any thoughts about what you see in this results and what it says to you about the state of payment in primary care during the pandemic.
Alyssa, thank you so much. Alyssa's being a little bit modest here. This is just the tip of the iceberg of the richness of the data that they've collected and have analyzed for us. So thank you, first of all, very much for for the work that went into that and for this wonderful presentation. I also wanted to just make sure that that we allowed either Julie or Aparna had any comments they wanted to add to Alyssa's before we get started with questions. I'd be happy to have that.
Nothing from me, Lisa. I do see we have a few questions in the chat, so.
Yep, we do. Okay, great. Thank you. So Dr. Shank came up with a couple questions right away, no surprise, but a very specific one was with regard to the temporary question or the issue around longevity, I guess, of these changes. Was that in reference to the specific issues around the pandemic, or was it in regard to the alternative payment methodology in general? Do you think you can answer questions?
So I pulled up the slide that I think you're referring to. Please let me know if you were thinking of something different. So the question that we asked, and we asked this question at a few different places throughout the survey, just to try to better understand how long payers expected this to be around, was, and I want to quote it directly because I don't want to misattribute what people might have read into this. For how long will these advanced or accelerated payments be available? That was the gray bars you see here. That was the question we asked there. And we asked the question basically worded the same way, but with a focus on the quality reporting requirement modifications for the bars in green. And this graph is just presenting the data from those two questions side by side, so you can see how similar, at least for these two questions, the responses to longevity seem to be. So I think in your question, Richard, you're asking if you want to focus specifically on how long the advanced or accelerated payments will be around, you would look at the gray, but the alternative payment methodology, I think, is really the box in green. That might be what you're referencing. And it was in the context of, you know, how long relative to the pandemic. And that's why you see the responses you do on the side.
So just a comment about that. I'm kind of surprised by that, actually. I would, if it's about this type of payment methodology in general, of, you know, continuing with this, and that the number that are saying they're not yet decided or may not, I don't know, is anybody else surprised by that? It seemed to me, and maybe I'm just working with a group of payers because it's of our penetration of CPC Plus in Ohio, but it does, I don't know, I would have expected more to say this is going to be something that they'll be continuing to do.
Just to double check though, advanced or accelerated payments is the idea that they're providing payments earlier to practices to give them earlier access to cash. Those are separate from the question about, are you providing increased access to alternative payment programs? Things like, you know, capitated payments or value-based modifiers.
Oh, okay. Okay, that helps. Okay, thank you.
I still would welcome reactions from anyone else if this matches your experience or not. I will also call attention to the fact that about half the payers weren't sure or had no response to this question about how long this will be around. So that might also be a reflection of what you're experiencing.
Okay.
Yeah, my expectation wouldn't be as high for the advanced payment. Certainly for the alternative payment models, I would expect that to be, it seems like payers have moved to that in many ways. So I would anticipate that it would be more ongoing. So.
Yeah, I mean, I think this is one of the problems with having only a limited number of words we can use.
Yeah.
Because there's advanced alternative payment models and then there's advanced payments. And so we sort of got ourselves in a box here.
We did try very hard in designing the survey to try to make that as clear as possible, but in summarizing it, it's, I think, even less clear. I will say, if it helps, that we did not ask a question about how long payers expected to increase opportunities for primary care practices to participate in alternative payment models like the one seen on this slide. You know, again, the value-based modifiers, the partial cap or full capitation. I think in part because we didn't expect that would necessarily change based on the pandemic. We did ask a question about how long they expect to, or sorry, not how long, sorry, how they are increasing opportunities and any differences across lines of business. And that's where, as I mentioned, there were some examples of how they're, you know, changing program policies or softening criteria in an effort to get more people to participate. So I think this does look like it's likely to be a much longer term thing, to your point, Richard.
Great.
And I see that you had another question. Should I just go ahead and address that one too, Lisa?
Sure, Alyssa, that'd be great.
So the other question you asked was, are payers seeing a significant group of practices that are unable to engage because the practice does not have the opportunity to learn how to conduct themselves in an advanced payment model? It's a great question. We didn't really ask a question that gets directly at this, so I don't know that we have a lot of insights, but I will just go ahead to some of the slides at the back just to show you some of the detail we saw around sort of the context for participation in programs. Let's see if I can find this slide. I guess I didn't put the quote in. I was going to say that the main thing we saw that I think is related to this is when we asked about impacts that payers are seeing. I think it was two different payers mentioned that the supports they are providing in response to the pandemic has actually led to an increase of how willing providers are and how ready they are to participate in alternative payment approaches. So it's not exactly the same as what you're saying, but I think there was some indication in the results we saw that this was definitely occurring. And I think there was also some indication that providing supports generally to primary care practices can make it easier to enter into those conversations about alternative payment programs. Others on the call might also have thoughts from their own experience about whether this is something others are experiencing in their interactions with primary care practices right now.
I would just add that it is a concern, although we've been lucky in that we have had the models that are multi-payer models that go out to the practices, so a significant proportion of the practices in Ohio. So, but I do know of several practices, especially smaller groups or even independent practices, that just don't feel comfortable getting into, say, primary care first, where they have to take on risks simply because they have no experience with how to actually make it work. And I think that's a concern I have, because the programs we put out there have really still touched across the country really a small percentage of the practices. And I think if we're going to see this continuing, I think it does need to be multi-payer, because practices would have a hard time handling 5, 10 different payer approaches to it. And so there needs to be some organization around it if we're going to get this to be more of the standard approach to the way primary care is delivered. So just to exercise my soapbox for a little bit, that's all.
Yeah, my sense in our state in Arkansas would be that, when you start to remove the burdens of overhead to primary care, they become more open to alternative payment models. The tricky part, I think, is going to be if the models don't remain, the fidelity of the model. If people keep changing the rules, or like Lucy in the football, you don't want to burn these people. They're fragile, but how much risk can they take? Probably not much. I think you can shape a lot of reform, but if you start putting financial risk on top of everything else, you may want to just, I think we should be happy with practice transformation and patient-centeredness, and reduced reliance on bricks and mortar visits. But you start throwing financial risk on top of it and people start to walk away.
Obviously, Alyssa, what you're hearing is an active, ongoing conversation and significant concern on the part of this group around what the future holds for continued primary care practice transformation in the multi-payer space. And that looks like that's been highlighted was from our colleague in Diana Bianco, saying there's a real need for technical assistance from the practice perspective as they try to move into value-based payment arrangements.
And I'm not surprised to hear that this is a thread of conversation that probably went well beyond today's conversation and before and after.
Okay.
I guess I would add that one thing I saw in the survey that I think is useful to consider is that there was a number of places where payers mentioned really targeting what providers they're supporting and how they're supporting those providers. And I think there's a reality where for some things, providers need the same types of supports and the same types of services, but I think particularly when we think about things with an equity lens, there are opportunities to think about how do you tailor how you support practices, and not you specifically, but the collective you. How do we support is a better way to say that, practices as they're making these changes, because there is a lot involved in that, but there's also a lot of opportunity in that I think is good to try to take advantage of and do in a partnership as much as possible.
To follow up on that point, I think that it's not just the provider group as a generic group. I think there's a lot, as you were pointing out, a lot of differences among practices capabilities. So if you're part of a large system, you have more capability than if you're a 2 or 3 practice group out in the more rural areas of the country. So it is I think we need to be thinking about the various environments that the practices are in and how do we engage them. So.
Thank you for this great discussion. There's one other pretty specific question also from Diana Bianco. Diana, I assume you're talking about community health workers, CHWs, and to find out.
Actually, Lisa, I'm talking about traditional health workers, which include community health workers, but also might include peers. And I don't know, Alyssa, I think you use THWs, but you may have said CHWs. Something we've been talking about in Oregon is there a way to do value-based payment to encourage the use of traditional health workers?
Yeah, so I think I did say traditional health workers because that was the quote that I referenced on this slide here about different approaches to addressing equity and disparities. I don't believe, I can go back and look, but I don't believe that the more detailed response to this question indicated how that is being paid for. There was sort of a variety of things going on at the same time. I will say that I know that in general, there is an increased focus on non-traditional healthcare workers, whether that be not non-traditional, sorry, traditional healthcare workers is actually the term here, but thinking broader when you think about types of healthcare providers. And I don't know whether the payers who responded to this question, or at least this particular payer, was using that approach, but I think there's a real opportunity there to think bigger and to think a little bit outside the box about how to pay for care for the right people to provide that care, and that team is getting bigger.
Thank you.
Thank you very much. So that's all that we had in the chat. Is there any other questions or comments? This is a lot of information, I know, to look at in a brief period of time. We will be providing a great deal of follow-up materials for all of you, with including the survey questions as a reminder, a slide deck with all of this information embedded, a high-level summary that our intern Sanika Kumar is working on. So we'll have a couple of different ways for you to be able to use this information and look at your own organization relative to what the results were from this survey. Any other questions or comments? Any big surprises looking at the information that Alyssa shared with us today? Okay.
I'll just add that it was good information. I thought it was good, very helpful and in perspective. So thank you.
My pleasure. I hope others found it helpful too. Although certainly if there were things that I went through too quickly, if you want me to pull up other slides, I can certainly do that, go back to things if people want to take a closer look.
Sure. Does anyone have any particular topics that they felt like they didn't get quite as much information as they'd like? Okay, well, this is really, first of all, Alyssa, Julie, and Aparna, thank you so much. And it's really it's been a pleasure, a delight to work with this team, I have to say, and we look forward to our continued collaboration. Yeah, any other comments?
Yeah, one last question. Do you have a sense from the survey or from the folks you chatted with, their comfort level with what they were buying? You know, did they have a feeling that there was that care was being delivered appropriately, or that there was a utilization, if you will, abuse potential? Do you have a sense of their comfort level with what the product they were getting in the alternative telemedicine market?
Yeah, it's a great question. So we didn't see any indication in the results we got that there were those concerns, which doesn't necessarily mean that they didn't exist. The questions we asked, we asked questions about what they're doing, and then the sort of more nuanced, open-ended questions mostly asked about facilitators and difficulties. And as I mentioned, there was one example of at least one payer who indicated some concern about the quality of the telehealth services and ensuring the quality of telehealth services as they were being used. But I didn't see a lot of indication that people were concerned about what they were buying. I think in general, the sense I got from the results was that most payers were just really eager and appreciative of having these alternative approaches to care, given all of the downsides of not having care. And although there was a lot of sort of headaches getting there, there was just a sense of appreciation after getting these new services in place and payments in place that they were being used. But yeah, that we didn't ask a specific question on that, so that might be part of why we didn't have the results that you're asking for.
It's a great question. I mean, and frankly, Bill, that really points out one of the ever-present quandaries in fielding a survey like this. You know, we of course it was longer than we had wanted it to be initially, and there were things that we added or that left out in retrospect maybe we would do differently. So it's always you make your choices and then you live with the data that you can collect. So but one thing that is, I think, exciting is that we've done this survey now twice in half a year, and we've gotten pretty good responses in both settings, and we feel that there is still much to be learned. So we look forward to potentially looking at this a third time moving into the future. So we'll see.
So
Hurwitz, looks like you might have a specific comment you wanted to just talk about a telehealth collaborative in Rhode Island.
I can just mention that we are working with the Northeast Tele-Resource Center on a telehealth collaborative that's been supported by both the CARES Act funding as well as United Health Plan funding. And it's kind of a three-part project. We started out with a survey, sort of a needs assessment of the practices, what they thought and felt they needed in regard to telehealth going forward, sort of coming, having everybody jumped into the pool all at once and sort of doing whatever kind of they could do. At this point, it was like, what can we do to help them really come out of this and feel like they're doing best practice? So we did a survey, got a lot of response from that. In fact, we got, I'm going to say like 47 practices. We also asked them to survey patients, and we got 900 survey responses from patients about how they received telehealth and what they thought about it. And from that, we worked with the Northeast, Telehealth Resource Center to sort of look at the data, come up with a webinar series of things that addressed some of the needs, like around billing and coding and, several issues. And then just recently launched a 12-month learning collaborative, kind of a deep dive, if you will, into remote monitoring. And that can take many different kind of looks. But we've got, I think, 21 practices that have signed on to that. And that's underway right now.
That's great. Thank you. Any other questions or comments?
I'll just make a comment that to kind of follow up on Deb's comment, that I've been very pleased and surprised that of the dozen or so payers that are active in the state of Ohio, I was impressed that the 90%, all but one really, saw a real opportunity in forums like this for a multi-payer type of collaboration, and to say, how can we make this work for providers going forward? Where can we streamline? Where can we reduce the burden? And can we do that as a group as opposed to all of us as individual plans doing them individually? So I found that very encouraging. And I don't know if anything in this survey spoke to that, or whether there was any talk about how payers can best work together.
Again, I think this is an example of a great question that I wish we had had space to ask, but didn't. The one place it came up was when we asked about facilitating factors. There was it was either 2 or 3 different payers who mentioned that they were collaborating with either public or other public or private sector payers, and that was part of their ability to actually implement these changes. So I think I don't know that it adds a whole lot on what you already know, but I will flag that I think there is a real benefit, not just for the providers, but also for the payers to be able to move forward with these solutions when they work together.
Well, I think you can sense the bias in this group, that it's always helpful to be working with colleagues. Great. Okay, well, once again, Alyssa, Julie, and Aparna, thank you so much for the work that went into this, and also a shout out to Sonika Kumar, who was very deeply engaged in this work as well on behalf of the fund. So as I said, there'll be quite a bit of information to follow. There'll be follow-up emails, and we will be posting all of this information on our website as well at the Milbank Memorial Fund, milbank.org.
Thank you, Lisa. We really appreciated the opportunity to work with you on this, and I think found it all very useful and this conversation very insightful. So I appreciate you giving us a chance to come and share what we've learned.
Absolutely. Thank you again. And feel free to stay on, or perhaps go back to your real jobs. Thank you. So I just wanted to have this opportunity once again to just talk a little bit about some of the primary care first activities that we hear about. Obviously, everyone knows that there has been the release of the RFA for both practices and providers. I'm sorry, practices and payers, with our sort of overlapping timelines for the application period. We are certainly hoping to be able to facilitate as much information sharing as possible, because we'd really like to make sure that any decision that payers make in this next couple of months is as informed as possible. And I think we do have good partnership from our colleagues at the Innovation Center, who are very keenly interested in increasing the numbers of multiple payers in this multi-payer effort. And obviously we're somewhat disappointed with the just the number of participating organizations in the first round. So they've set up, as you know, a series of webinars with information. They are making themselves available to individual payers. I would encourage you to do direct outreach to people like Krista Spiker and Nick Minter. They would be happy to talk to you if you have questions, concerns, suggestions for how this is moving forward. One particular thing I did want to share is that we are going to once again try to bring our colleagues from the Medicaid state agencies into the primary care first loop, with once again having some more targeted opportunities for people who are working in Medicaid in the 26 states that are part of this process to be able to participate. So we're in the throes right now of setting up a specific webinar that will be staffed by obviously the Innovation Center people, but also we have some very well-informed colleagues at Medicaid who would be they're very excited about the opportunity to try to share as much information as possible, and obviously try to figure out what those hurdles are for Medicaid state agencies, which are not insignificant, as trying to modify the way they do business to be able to participate in primary care first. So that I think will probably be a webinar at the end of April. Stay tuned. I'll be obviously going to be making that available to anybody who wishes to be part of it, but specifically targeted at our colleagues who are working in Medicaid in all these states. I wanted to give you some follow-up about the letter that I had sent on behalf of the network to the new leadership at CMMI. So we sent, as many of you recall, we had a letter that many of you were involved in the editing of and suggestions, and got approval by consensus, and also some explicit approval from individual organizations that signed on to the letter. This was in support of a menu of options for primary care practices beyond just primary care first as their only opportunity to work with the Innovation Center in an alternative payment model moving forward. So I sent that off, I don't know, I think it was maybe 2 weeks ago. Within half an hour of my sending it by email, I had received a response from Elizabeth Fowler, who's the new director of the Innovation Center, thanking me, thanking the network, very appreciative of our input and of our support for their work. I was very surprised to get that kind of a rapid response, and really happy as well, because it signaled to me a level of engagement that I think would be very beneficial moving forward. That being said, I don't think there's any question that this CPC Plus, as we know it, will sunset as scheduled. And the next phase, whatever that is, certainly is primary care first that we know of. And if there are going to be other opportunities, it's not clear yet what those are. But that doesn't mean we should give up the fight to really push for a continuation of some of the interventions of the CPC Plus, and perhaps other opportunities that people would be willing to advocate for. So I'm not discouraged, at least not completely, but I think we need to put our heads together to try to continue to place some, I think, appropriate pressure on the new leadership, on the current staffing at the Innovation Center, on behalf of the practices that are really benefiting from CPC Plus moving forward.
Lisa, one thing that comes up, and I think people are still finding, how the phones work, and the way around the buildings. But even this morning, there's a new news feed that the Rural ACO chart initiative is postponed a year. So I get the feeling that there's a lot of things being reassessed and in flux as people actually sit down and read the documents they've inherited. So maybe there's an opportunity, if we come up with specific recommendations and suggestions, that I have a feeling that lots of things are being re-looked at with the new folks in the building.
I think that's entirely right, Bill. I think that's completely correct. As usual, there's people are as forthcoming as they can be. Actually, is that a politic way to put it? There's only so much they can share, and I think there's only so much that they actually know, as you said, because of the this is a change in administration, change in leadership, and I think that there's an openness and a willingness to engage in discussions that wasn't there previously, but whether anything can actually happen between now and the end of this calendar year that would provide continued opportunity for the practices that aren't yet ready for primary care first, and the risk involved in that remains to be seen.
Lisa, this is Dan from Oregon.
Hi, Dan.
How you doing?
Good.
Good. I just got done spending a week or so digging through the American Rescue Plan Act, and what I was doing it for another purpose at the center, but I'm now wondering whether or not I should go back through the act again to see whether or not there are any ways to align this effort that we're talking about with CPC Plus and primary care with provisions in the act. And so I'm wondering whether anyone on the call has been looking at the act with that in mind, with primary care in mind.
Wow, Dan, that's great. but I'll just sort of put that out there. Has anyone been, first of all, isn't it 800 pages long or something like that? I thought it was.
Yeah, there are 215 separate sections, and the language, as you would expect in federal law, is very dense. I'll be an analyst for a long time.
Absolutely.
I just got off, right before this call, I got off a call where somebody was going over the act. And there's a lot of emphasis about community-based health services. But I didn't hear a lot in the discussion about primary care or about primary care first kind of things. There was some stuff about Indian health services. There was some infrastructure materials for FQHCs. But I didn't really hear much being discussed about alternative payment. And aside from like, community-based service kind of supports.
Right. Well, I think we can, one of the things we can do, Dan, is offline, you and I maybe can connect with the PCC, the Patient Center Collaborative, the Primary Care Collaboratives, just to get some sense of what they're looking at, because they have that finger on the pulse around the legislative agendas. So that might be helpful.
Sure.
Great. We can do that.
Yeah.
Okay. All right. Well, I want to be respectful of time. It is 2:30. Thanks everybody for joining us today. A quick reminder: you'll be getting an updated invitation to our virtual seminar, which is on the 12th of April. We're focusing on behavioral health integration with primary care. And we're really excited to have 3 fabulous sets of presenters from 3 different regions involved in this work in the CPC Plus. We'll be sending out more detailed information by email in the next week or so. Hope you can join us then. Thanks everybody for being part of this today. And again, thanks to our colleagues at Mathematica. Bye everyone.
Thank you, Lisa.
Thank you.
Have a good one. Talk to you soon.
Thank you.